Okay, so hello again. My name is Erin Terseño for those of you who do not know me yet. And today I will be presenting my continuing education presentation on Don't Miss a Beat Optimization of Treatment for Acute Decompensated Heart Failure. I have no disclosures, and I would like to acknowledge Joe, Amanda, and Caesar for their help with this presentation. Our objectives for today will be to explain the pathophysiology, etiologies, and prevalence of acute decompensated heart failure, or ADHF, identify medications that may exacerbate heart failure, be able to differentiate therapeutic options for the management of ADHF, then apply pharmacodynamics, dosing conversions, and bioavailabilities of loop diuretics used in heart failure to clinical patient cases. And lastly, finally, be able to generate an individualized strategy for relieving symptoms using evidence-based literature when we're given a patient case with acute decompensated heart failure and volume overload. Starting off with some statistics, it is estimated that over 1 million hospitalizations per year for heart failure in the United States and Europe, and the readmission rates for these heart failure hospitalizations are somewhat high. We see about 24% within 30 days, and this is increased to 50% within 6 months. It is also estimated that about 80% of all heart failure hospitalizations are from admissions from the emergency department. And the reason that I'm spending time talking about these readmission rates is because 1 in 6 patients admitted for heart failure are estimated to die within 30 days of their hospitalization. So I think today, when we spend some time talking about the treatment and guideline recommendations for acute decompensated heart failure, integrating these in practice can really help potentially decrease these readmission rates. Now, before I circle into talking about acute decompensated heart failure, I think it might be important to take some time and talk about chronic heart failure and the pathophysiology. Because really, acute decompensated heart failure in general terms is sudden worsening of chronic heart failure symptoms. And there are a few types as well as a few causes. For starters, there's left-sided heart failure when the heart is either unable to fill with blood during diastole, and these patients will have a preserved ejection fraction greater than 50%, or it will be unable to pump blood during systole. So these patients will have a reduced ejection fraction less than 40%. And then there is also right-sided heart failure, which typically occurs as the result of left-sided heart failure. Because when that left ventricle fails, there'll be an increased fluid pressure that's eventually going to be transferred back into the lungs, ultimately damaging the heart's right side. And when the right side is failed and it loses its pumping power and ability, blood will then back up into the body's veins, which leads to a lot of signs and symptoms consistent with fluid overload that we're going to be talking about later on in this presentation. Now I'm going to explain a little bit more what I mean by preserved and reduced ejection fraction. So on your screen in front of you right now is a picture of a normal, healthy heart that is contracting and filling as it should be. We have in the blue lines deoxygenated blood. So it's going to come into our right atrium through the tricuspid valve right now down to the right ventricle, go out into our lungs to get oxygenated. It will then return back through the left atrium down to the left ventricle and then out through the aorta to our body to supply our body with oxygen-rich blood. With left-sided heart failure, if we have a patient with reduced or preserved ejection fraction, the problem here is the heart becomes stiff and thick walls. And what that means is it's going to prevent the blood from being able to fill during diastole. And this will result in a preserved ejection fraction greater than 50% in diastolic heart failure. Comparing that to systolic heart failure, this is when the heart walls may become thin. And because they are thin, they do not have the power to contract, to push that blood out into the body, resulting in an ejection fraction that is reduced less than 40%. And really, all of this leads to a lot of left-sided signs and symptoms of heart failure. For starters, there are rales, which are really cracking sounds that are in the lungs heard on a lung exam by a physician. Orthopnea is common, so shortness of breath when laying flat. There's also potential for paroxysmal nocturnal dyspnea, so shortness of breath at night, as well as potential for nocturnal coughs. And like I talked about before, we're having a problem with perfusing our body and pushing that blood out to perfuse our end organs. So there is going to be hypoperfusion. A way to look for this can also be looking at cool extremities. And then finally, there's an S3 gallop that can be heard when our physicians are looking at the heart sounds, which is really an abnormal low-pitched heart sound that occurs as a result of a large amount of blood in the left ventricle. Because all of this is happening, the body is going to try to compensate for that decreased cardiac output. And there's a few ways it can do this. First and foremost, it will activate the neurohormonal pathway and the sympathetic system. For example, increase norepinephrine. And what this will do is increase the heart rate, increase contractility to increase the cardiac output. It'll also activate our renin-angiotensin-aldosterone system, or our RAS system, to increase fluid retention and preload to also increase that cardiac output. And finally, the heart will have myocyte growth or hypertrophy, and that will also help increase cardiac output. So for the beginning stages of chronic heart failure, our body does a good job at compensating to increase cardiac output, to push that blood out to perfuse our end organs. But over time, our body will get overwhelmed, and this compensation will eventually lead to a further demise on a downward spiraling cascade that can really present patients with acute decompensated heart failure. So what causes heart failure? There are many conditions that may lead to heart failure. I have a few listed on this slide for your reference. For instance, coronary artery disease. So if we're thinking about an artery that's blocked, this means that blood and oxygen will not be transported to the heart. And that leads in a consequence of that heart getting weakened because it's ischemic, leading to systolic heart failure and a reduced ejection fraction. And that really goes hand in hand with myocardial infarctions because of that ischemia. Thinking about hypertension, if we have patients that have uncontrolled high blood pressures, this will cause the heart muscles to get hypertrophy, get thick, and therefore it cannot relax, leading to diastolic or patients with preserved ejection fraction. And as pharmacists, I'm sure we all know there are many medications that can exacerbate heart failure as well. So I have a mnemonic here to help us memorize some of these drugs in DI Nation, as you can see on red on the left-hand side. So the D stands for our DPP-4 inhibitors like saxagliptin or sitagliptin, and really this is an overall class effect. Our I is for immunosuppressants like our TNF alpha inhibitors, which is thought to be a cytokine mediated result, and interferons as well. And then we have our non-dihydropyridine or non-DHP calcium channel blockers. Verapamil and diltiazem are listed as major exacerbators of heart failure due to negative inotropic effects. However, I would like to spend the time to note that there is one DHP calcium channel blocker, nifedipine, that's actually listed as a moderate potential to exacerbate heart failure. Antiarrhythmics can also exacerbate it. So class 1, class 3, because they also have a beta blockade. If we're thinking about what might be a good option as an antiarrhythmic for a patient with heart failure, amiodarone and ticacin might be a good option. We have our TZTs, pioglitazone and rosiglitazone. And the I stands for itraconazole. So itraconazole specifically, the FDA recommends to avoid use in patients that have heart failure. And of course, itraconazole is an azole antifungal, and there are many other azole antifungals like fluconazole, posaconazole, ketoconazole. And these all have cardiovascular adverse effects like risks of torsades, QTc prolongation, but there are no specific cited risk that reports heart failure exacerbations. Other azole antifungals that you might be thinking about is like amphotericin B and its liposomal formulation. There are several cases of new onset dilated cardiomyopathies that lead to subsequent heart failure. But then again, itraconazole is the only azole antifungal that the FDA recommends to avoid use in patients with heart failure. Oncology drugs can be an exacerbator due to their oxidative stress, and the most noted offender is our anthracyclines. So, for instance, doxorubicin, and this is because they have prolonged oxidative stress that is caused by a secondary alcohol metabolite, and alcohol in itself is cardiotoxic. And lastly, N stands for NSAIDs, are COX inhibitors, non-selective and selective. So ibuprofen, naproxen, you name it. These are all potential agents that can exacerbate heart failure. Now, I wanted to include these medications. I think these are meds we might see more often that's not included in that mnemonic that I wanted to bring up. So antidepressants, specifically tricyclic antidepressants, they have numerous cardiovascular side effects like tachycardia, QTc prolongation, and the FDA does recommend avoiding use in patients with acute decompensated heart failure. Donepezil is another one that we might see more often that should be used in caution with patients in heart failure because they can change the heart rate and they include AV block as well as potential risks of torsades. And lastly, pregabalin. The FDA recommends using caution in patients that have more severe chronic heart failure because of an increased risk of edema. Now thinking about our signs and symptoms that are consistent with acute decompensated heart failure, really, these signs and symptoms actually might be present for patients that have chronic heart failure at baseline. But the key is when they have an acute exacerbation, these signs and symptoms will either worsen or they'll have new onset. To give more of an example, these patients might have swelling in their extremities at baseline, which leads to frequent calls to their providers to make adjustments to, for instance, their diuretic regimens. But if these patients see something like rapid weight gain, so we're talking about 2 to 4 pounds per day or 3 to 5 pounds per week, this should really be a red flag to these patients with chronic heart failure that they should potentially be having medical attention to address an acute decompensated heart failure exacerbation. Now talking about laboratory monitoring. The biomarkers that we may look at when assessing a patient case with acute decompensated heart failure are BNP and NT-proBNP. These are both natriuretic peptides that are a family of protein hormones, and they are released by the cardiac ventricles in response to volume expansion as well as pressure overload. So they're increased when the cardiac myocytes are strained, and they're increased because they help by a few mechanisms. One being they'll act on blood vessels, causing them to dilate. They also work in the kidneys, causing them to excrete more salt, followed by more water. And they also downregulate the central nervous system or the sympathetic nervous system and the RAS system. So overall, all of these mechanisms will facilitate natriuresis, so removal of salt, diuresis, removal of that water, and reduce vascular resistance. In general, both of these values are reasonable correlated and either can be used when we're thinking about patients presenting with acute decompensated heart failure. They're both the most studied biomarkers in heart failure, and using them has actually been shown to save money in emergency department settings because they play a role in both diagnosis as well as prognosis. So typically these levels will be low, less than the numbers that I have highlighted in red here in a healthy human, and they will be elevated in patients with acute decompensated heart failure. So for instance, higher values have a reasonably high positive predictive value to diagnose heart failure. And a low, for instance, BNP level is highly effective at ruling out heart failure. Therefore, if we have a patient, for instance, presenting to the emergency department with dyspnea or orthopnea, and we're not sure if it's an acute decompensated heart failure case, if these levels are normalized, we can be estimated about 90 to 98% sure that we can rule out acute decompensated heart failure. I would like to note, though, there are many other reasons why these levels can be increased or decreased, and that's other cardiac reasons and non-cardiac reasons. So for instance, acute coronary syndrome, atrial fibrillation, renal failure, severe burns, and even increasing age can increase these levels. A lot of the medications that we use for patients with chronic heart failure will actually reduce these levels. So things like our ACE inhibitors, spironolactone, and our diuretics. The caveat to that is specifically the Numera medication Entresto. So this is a neprilysin inhibitor mixed with valsartan. And this can actually increase the BNP level. And the reason for that is because it will inhibit the BNP degradation. Therefore, if we have a patient with Entresto and our providers want to monitor how they're doing on their medications, we could maybe recommend to assess the NT-proNB level as a more reliable biomarker than BNP. Thinking about some key monitoring, there's this pulmonary artery catheter, also known as the Swan-Ganz catheter, or it's also called a right heart catheterization. It's the passing of a catheter, or really a thin tube, into the right side of the heart and the arteries to monitor the heart's function and pressures around the heart. And this is going to tell us our cardiac index, which is the degree of perfusion, and the pulmonary capillary wedge pressure, which reflects the fluid status or preload. To break these levels down a little more in depth, so when we think about cardiac index, like I said, that's the perfusion status. Another way we can describe these patients is warm or cold. If they have a normal cardiac index, they would be considered warm. And if they have a reduced cardiac index less than 2.2, this means those patients are hypoperfused. Their blood is not pumping out to adequately perfuse their end organs, and they would be considered cold. The pulmonary capillary wedge pressure, on the other hand, is the volume status. Also, we can describe these patients as dry versus wet. So if it's normal, they would be dry. There's no fluid overload. And if they're wet, they would have a pulmonary capillary wedge pressure greater than 18. And I spend a lot of time talking about this because these two values play a major role when we're thinking about classifying patients with acute decompensated heart failure. And once we classify them, that's going to drive our treatment. So when I say classification, we classify based off the 4 esters hemodynamic subsets numbered 1 through 4, based off of what I just told you on the last slide. This is more for your reference to look at the values, but I think this slide does a better job at visually showing you the different classifications. Really, the main 2 questions we are going to be asking with acute decompensated heart failure is 1, does this patient have congestion at rest? Yes or no? If the answer is yes, remembering that means they'll have an elevated pulmonary capillary wedge pressure greater than 18. And the second question is, do they have low perfusion at rest? Yes or no? And if the answer is yes, they're going to be dry with a reduced cardiac index. And this, like I said, is going to drive our treatment. So I'll first start talking about classes 3 and 4, and both of these subsets have a commonality of low perfusion at rest or a reduced cardiac index. There are other ways we can assess for perfusion status. We can calculate patients' narrow pulse pressures. For example, if a low proportional pulse pressure is less than 25%, that's a good correlator with a patient having a low cardiac index less than 2.2. And we can also look to see if patients have cool extremities, which is a major indicator of low perfusion. Our treatments of choice here then are going to be positive inotropes, so dobutamine, milrinone, or dopamine. And that's because they're going to augment contractility or strengthen the contraction of the heart to push that blood out to increase that cardiac output, stroke volume, increase perfusion, and it can even lower our pulmonary capillary wedge pressure. Really, a positive inotrope should only be used though in a specific subset of patients, so those in 3 or 4, with symptoms and signs with cardiogenic shock, meaning they have acute decompensated heart failure, hypotension, and hypoperfusion. We want to save it for patients that have that hypotension with a systolic less than 90. And if we're thinking about class 4, right here, if they're cold and wet, it's only indicated for patients that have not responded or are not tolerating IV diuretics and vasodilators. The goal overall here is going to be relieving symptoms as well as preventing end organ damage. Dobutamine is an inotrope of choice in these patients because it does possess greater positive inotropic effects than other inotropes that might not even be on this slide, like norepinephrine. And dopamine has traditionally been used in the study of cardiogenic shock. However, recent literature has shown that dopamine might be associated with greater risk of adverse events, which makes sense if we think about the mechanism of action of dopamine. It's more non-specific, and there's potential for it to act on alpha, beta 1, beta 2, and dopamine receptors. So now if we're in between choosing dopamine and milrinone, there's a few ways we can pick, and that kind of coincides with its mechanism of action. So dobutamine is a beta-1 agonist and milrinone is a phosphodiesterase 3 inhibitor. I have the dosing listed on this slide for your reference. Both are in micrograms. And key with milrinone is the dose needs to be reduced in patients with reduced renal function when their creatinine clearance is less than 50 mils per minute. And this is because if we do not reduce the dose, the drug can accumulate and lead to an increased risk of adverse effects. And there are many adverse effects of positive inotropes, most notably being pro-arrhythmic. Now circling back to dobutamine, dobutamine is generally recommended to be avoided if a patient is on a beta blocker, which makes sense when we're thinking about that mechanism. So it's a beta-1 agonist. If we're also using a beta blocker, that's going to really reduce the efficaciousness of dobutamine. And then we also want to make sure we're correcting magnesium and potassium disturbances prior to initiating dobutamine, because again, it has the pro-arrhythmic potential. And its half-life is relatively short at 2 minutes. Milrinone, on the other hand, it can be used in patients that are receiving a beta blocker, and we must have like hypomagnesium and hypokalemia replenished prior to initiating. And the reason that this definition is more stringent than dobutamine is when we think about the pharmacokinetics. So milrinone has a much longer half-life of about 2.3 to 2.4 hours, and this half-life is even increased, especially with patients with reduced renal function and more severe heart failure. So that's really increasing the time that we have this risk of adverse events. Overall, these medications should only be used in the specific subset of patients if patients are hypotensive, because there is also potential mortality associated with increased long-term use. And to back that statement up, I'll present this trial. It's called the Optum-HF trial, a randomized controlled trial in 2002 that looked at about 951 patients. They compared milrinone to placebo in patients that presented within 48 hours with known systolic heart failure and ejection fraction less than 40%. They excluded patients if they clinically actually required inotropes. So if they had a low reduced systolic blood pressure, if they had evidence of ischemia, so going against everything I just said on the last slide, which the patients we want to use these drugs, they excluded them. And they found that the mortality in hospital and at 60 days, when compared to placebo, there was no difference. So there was no benefit of using milrinone, but there was a significantly increased risk of failure of therapy due to adverse events just within 48 hours. And these adverse events range from excess sustained hypotension, new onset atrial fibrillation, a flutter, as well as VTAC and VFib. Really now the Optum-HF trial is concluding then that IV milrinone is not recommended as a routinely used agent as an adjunct to standard therapy if patients are not in that class 3 or 4 hemodynamic status without cardiogenic shock. So there is a place in therapy, and these agents are definitely helpful, but they should not be used as routine agents for patients that do not fit the criteria. So given that information, I have the first patient case. We have a patient admitted for acute decompensated heart failure. They are fluid overloaded, and they have some signs of reduced perfusion. They have cold extremities and a somewhat reduced cardiac index of 2.1. However, I would like to note that their blood pressure seems okay. I didn't give you a baseline, but 110/80 is not super worrisome, and their O2 sats are doing well. So breaking that down, I think the first part of this question is kind of thinking about where does this patient fall on the hemodynamic classifications. So if we're thinking of congestion at rest, the answer is yes. And then if there's low perfusion, the answer is yes as well. So what class, if you want to type in the chat or say it out loud, do you think this patient is classified as? 1, 2, 3, or 4? Exactly. So 4. So now given that information and knowing that we have not used any other agents at this moment, what would be the best regimen to initiate when the patient first presents to the emergency department? Keeping in mind, again, they are fluid overloaded. So the answer here is going to be furosemide. And the reason for that exactly is because they are presenting in this class 4. And like I talked about before, we want to make sure we're using other options before we try an inotrope. And this patient is satting okay at the moment and their blood pressure seems all right. We would of course monitor though and change therapy if needed. I will now transition into talking about patients who have congestion at rest, so class 2 or 4, and both of these have an elevated pulmonary capillary wedge pressure of greater than 18. There are a few ways on a physical exam actually to identify fluid overload. Jugular venous distension has been found to be one of the most useful H&P findings and honestly the most obvious sign for assessing ventricular filling pressures. It's very common among patients that are presenting with acute decompensated heart failure. And because it's associated with that elevated ventricular filling pressure. So the heart is so weak, it cannot pump blood out into the body. There is this consequential backup of the venous system into the vein, and that leads to this bulging jugular vein that you can see on the picture on the right-hand side. There is also a hepatojugular reflex that our physicians can assess for by holding continuous pressure on a patient's abdomen and looking for a sustained increase in that jugular venous pressure. So those are the signs of fluid overload. On the next slide, I have the symptoms of fluid overload. And some of these we might already be familiar with, and we've kind of already talked about it. So orthopnea, abdominal or peripheral swelling, as well as pitting edema. Now, given that these patients in 2 or 4, they all have signs of congestion and fluid overload, can someone maybe think about what medication class is going to be our mainstay treatment to reduce the signs and symptoms of fluid overload? Yes, exactly. So the answer here is going to be our diuretics, because these are going to really reduce those signs and symptoms. However, there isn't a lot of robust evidence to support its mortality and morbidity, but it is really a first-line mainstay treatment for these patients. And loop diuretics are commonly used due to their rapid onset of action and proven efficacy in a multitude of trials. Now you might be asking, when is the good time to initiate this diuretic therapy? There was this observational cohort study in 2017 that evaluated a time to diuretic therapy and how that helped with patient outcomes. And they found that patients that were treated with a diuretic intravenous within 1 hour of their admission to the emergency department, there was this improved outcomes and potential increase in mortality benefit. Now, on the last slide, I said there isn't as much evidence to support mortality and morbidity with our diuretics, but this trial did show there is a potential. Also, the guidelines when we're thinking about how to dose intravenous diuretics, it's recommended to dose at 1 to 2.5 times a known oral dose. And if patients are diuretic naive, we can recommend furosemide 40 to 80 milligrams or Bumex 1 milligram. Now, general questions given this information that might arise when approaching patients hospitalized for acute decompensated heart failure is whether it's preferable to give intermittent doses or continuous infusions, and really what should that initial dose of the loop diuretic be, given that the guidelines recommend this major range of 1 to 2.5 times. So I will talk about a trial that really addresses both of these questions, but first I wanted to note as a little clinical pearl, if we do have providers recommending and preferring continuous infusions, it is still a good option to recommend a loading bolus dose to achieve steady state quicker and diurese these patients quicker. The diuretic optimization strategies evaluation or DOSE trial was a randomized controlled trial that included patients admitted within 24 hours of acute decompensated heart failure. They had to have a history of chronic heart failure and had to have been on a furosemide oral dose of 80 to 240 milligrams. They then assessed these primary endpoints. The efficacy endpoint was the global assessment of symptoms, which really was a visual analog scale, and it quantified as the AUC of serial assessments from baseline to 72 hours. For example, then patients were asked different questions to assess their overall well-being. So they asked, were you how you felt, and then they had to put it on a scale of a 10-centimeter vertical line, with the top labeled the best you have ever felt and the bottom of that line being the worst you've ever felt. They also got asked questions about dyspnea. So at that top of the line being, I am not breathless at all, and the bottom of the line being, I am as breathless as I have ever been. And then they scaled the score by 0 to 100 by measuring the distance between the bottom to the top of the line. They also looked at a primary safety endpoint of the mean change in serum creatinine over 72 hours. They included patients with a mean age of 66 years old. The majority were males, and these patients were a little more severe, as the majority of these patients did have a hospitalization for their heart failure within the previous year, and the mean ejection fraction was reduced at 35%. They randomized these patients to receive either a low dose of furosemide or a furosemide equivalent dose, which was a dose equal to their total oral dose, meaning that if a patient was getting 40 milligrams of oral daily Lasix at home, they gave them 40 milligrams of IV in the hospital. They also compared this to a high dose furosemide strategy, where they gave an IV dose 2.5 times the total oral dose. So if a patient was getting 40 milligrams oral at home, they then gave them 100 milligrams of IV. And they gave this either as an IV bolus every 12 hours or as a continuous infusion. And when we compared the bolus to continuous infusion, there was no significant differences between the two treatments in terms of the primary efficacy endpoint, as well as that safety endpoint of a mean change in serum creatinine. They did, however, found a statistically significant difference in terms of the dose increase requirements. So the bolus groups did require more frequent dose increases than the continuous infusion group. However, there was no difference between bolus and continuous in terms of their likelihood to switch to an oral diuretic at 48 hours. And this is important to note because the guidelines recommend, once we have reached our goals in euvolemia, it's recommended to switch these patients from IV to oral. Then looking at high versus low dose, there was a non-significant but numerical trend towards greater improvement in that primary efficacy endpoint in the high dose group. There was no significant differences in the primary safety group, again, of mean change in serum creatinine. And the patients who got the low dose of furosemide did significantly require more dose increases. And patients who received high dose furosemide were more likely to switch to an oral regimen at 48 hours. So even though this primary efficacy endpoint is non-significant, there was an overall trend to more favorable outcomes for patients who received the high dose of 2.5 times their oral dose. They had a greater net fluid loss, weight loss, and relief from dyspnea. However, this potentially favorable effect of high-dose furosemide was kind of balanced with a higher proportion of patients meeting this secondary safety endpoint, which was the increase in their serum creatinine greater than 0.3 over 72 hours. And to kind of conceptualize this a little bit more, our KDIGO guidelines for nephrology state that a patient who has an increase in serum creatinine of 0.3 over 48 hours is known to have acute kidney injury. So 23% of patients in the high dose strategy were significantly more likely than the 14% of patients in low dose to have, over the course of 72 hours, an increase in their serum creatinine by 0.3. But when we looked at these levels on a more longer scale, at 60 days, there was no difference. And this goes hand in hand with our primary safety endpoint of the mean change in serum creatinine. There was non-significant differences in that change with bolus versus continuous and low dose versus high dose. And then this was another outcome that they looked at I thought was interesting to share. They found that patients who were given low dose of furosemide actually had significantly more serious adverse events. In conclusion, then the dose trial concluded that high dose versus low dose, bolus versus infusion, there were no difference in global assessment of symptoms, no difference in the change of the mean creatinine from baseline to 72 hours. However, the bolus dose group did have greater fluid loss, weight loss, and relief of their dyspnea. Now, this data suggests that maybe a more aggressive approach to loop diuretic dosing is generally preferred potentially over cautious dosing. And what do I mean by high dose? I use this table to cross-reference different references that talk about the recommended max daily diuretic doses. And for example, if we're thinking about furosemide, generally the consensus is 600 milligrams should be the max, which is equivalent to about 200 milligrams per dose. Now, if we're thinking about, and maybe we're concerned about verifying orders for these high doses of Lasix, what is a risk that you might be thinking of if we're thinking of high doses that get high peak concentrations? And the answer here is ototoxicity. And the reason for this, the mechanism is actually kind of cool. So basically, loop diuretics inhibit the sodium potassium chloride channel in the thick ascending tubule. There is an isoform of this channel in the inner ear that it plays a role in what's called endolymph. And endolymph is this extracellular fluid that plays a vital role in terms of hearing. So if we're inhibiting this channel and that's thereby inhibiting the isoform, there is this potential for transient ototoxicity or permanent deafness. However, this is only seen at very high serum concentrations from very large doses of furosemide, greater than 2 to 6 grams per day. And if we remember on this last slide, we should really be looking for a max furosemide dose of 600 milligrams. But it is still a risk, and it's something to be aware of, and the risk is exacerbated in patients that have acute kidney injury. Now, my last conversation about loop diuretics is we know there are multiple diuretics, so I wanted to include this table for your reference. We have furosemide, torsemide, and bumetanide. I have the relative PO potencies for conversions. So 40 of furosemide is generally considered equivalent to 20 of torsemide and 1 of bumex. And I will remember that for the CE questions. And then I wanted to take the time to talk about the PO to IV conversion of furosemide. So PO to IV is really 2 to 1. It's not 1 to 1. And the reason I'm spending some time thinking about that is because in practice, as well as in a lot of these trials where they're evaluating loop diuretic dosing, they're not utilizing this PO to IV conversion, meaning that in these trials and in practice, if we have a patient presenting with acute decompensated heart failure that's on, for instance, 20 milligrams daily at home, we're giving 40 milligrams of IV instead of converting that 20 to 10 milligrams of IV and then doubling that 10 to 20 milligrams. So they are pretty aggressive in terms of the dosing. Thinking about oral bioavailability, this is less important in acute decompensated heart failure because we're really going to be verifying orders for intravenous diuretics, but it is something to know in terms of chronic heart failure. So furosemide is highly erratic in terms of its bioavailability, whereas torsemide and bumex are a little more reliable with a mean of about 80% bioavailable. Overall, high-dose furosemide does demonstrate trends towards higher rates of diuresis, improved overall outcomes, and there is, though, that potential for an increases in creatinine at greater rates, but this can be transient. So why do we think we're seeing this trend towards improved outcomes and rates of diuresis? And this can really be explained by our diuretic dose response curve. On the x-axis, as you can see, I have the diuretic dose, and on the y-axis is the response. And the first level I want us all to look at is that diuretic threshold line. This means that we need to be verifying orders with a high enough dose to reach that threshold to achieve diuresis. If these doses are not high enough, there is not going to be a response. The second line, though, to pay attention to is ceiling doses. So there is a point where this line plateaus, meaning that if we give a higher dose at some point, it's not going to elicit more of an effective response. But this curve is a log linear relationship between dose and response, meaning that a 20 milligram increment in a dose from 20 to 40 milligrams will produce much larger increases in diuresis than when we're thinking about 220 milligrams, increasing that to 240. So how does this play a role in heart failure? Well, in heart failure, this curve is going to be shifted down and to the right. And what that means is our diuretic threshold is also going to be pushed to the right. We need to give much higher doses in order to receive a response of diuresis. And that does support what we're seeing in practice, as well as in these trials of being a little more aggressive when we're giving these bolus doses of diuretics. And why does this happen in heart failure? Diuretic resistance can happen, which is really described as an inadequate quantity of natriuresis or diuresis despite an adequate diuretic regimen. And resistance can broadly be divided into pre-renal and intrarenal causes. However, the pre-renal mechanisms appear to be less important in patients with heart failure, whereas the intrarenal mechanisms dominate. And we already really talked about the doses being too low on that last slide, but the second major significant mechanism for resistance is this compensatory distal tubular sodium reabsorption. What does that mean? So if we think about this conceptually as a mechanism, loop diuretics act in that thick ascending tube, and they will inhibit the amount of sodium chloride that is going to be reabsorbed. So therefore, it's going to increase the amount of sodium chloride that's being pushed into the ladder of the tubule at the distal convoluted tubule. And this increases the ability of the sodium chloride channels to reabsorb sodium chloride at the distal convoluted tubule. Another potential that leads to this resistance is the nephron can remodel and have hypertrophy. So in the distal convoluted tubule, it can thicken and upregulate those sodium chloride channels, thereby again increasing the opportunity to reabsorb sodium chloride followed by water, leading to a demise in our diuresis. How do we know if a patient is resistant to a diuretic and what should be a response? Really, we want to target complete decongestion and euvolemia. There also are some goals during the first 6 hours. So a goal urine output of greater than 100 to 150 mils per hour. But this really depends on adequate and sufficient in and out monitoring, which can be hard. So there's also potential to look at the urine sodium content with the goals of 50 to 70 MEQs per liter. And overall, once we have achieved a response, it's recommended to transition to an oral regimen when the patients are clinically stable. If a patient has an unsatisfactory response, there are a few things we can do. First and foremost, the recommendation is to give additional boluses at an increased dose, so maybe double the loop dose we've already given, according to the 2020 expert consensus by the Journal of American College of Cardiology, or we can increase an infusion rate. If that doesn't work, there is a potential to utilize other diuretics that act at different sites. So we can utilize thiazides like metolazone or intravenous diuryl that will act at the ladder in the tubule. If this does not work, there is still more options. So we can use intravenous vasodilators. These will reduce pulmonary congestion, but they need to be used in patients that are not hypotensive. So they should only be utilized in patients that have MAPs greater than 50 because they can cause hypotension. And the mechanism of action here is really to reduce left ventricle filling pressures, preload and potentially afterload, especially at higher doses if we're thinking about nitroglycerin. Of note, of course, these medications are contraindicated in use of PDE5 inhibitors because of that risk of hypotension. And on the right-hand side on this table, I have spacing requirements for your reference. So if a patient is on Cialis at home, we should really be separating all these nitrates for 2 days. Comparing these agents, I'll start off on the left-hand side with nasiratide. There was this trial in 2002 called the VMAC trial that compared nasiratide to placebo and nitroglycerin. And they found that nasiratide resulted in improved global clinical status and patient outcomes. However, what they didn't tell you in this trial is that patients in the nitroglycerin group did not get therapeutic doses that are recommended for acute decompensated heart failure. And this has also been refuted in a lot of more recent multi-center randomized controlled trials. So for instance, the ASCEND-HF trial in 2011 showed that there was no difference in symptoms and mortality when nasiratide was used, and there was also this increased risk of hypotension. Thinking about nitroglycerin, the ADHERE trial supports its use and found that there was a quicker discharge and a decrease in mortality when patients were treated with nitroglycerin over patients treated with our inotropes, milrinone, and dobutamine. And lastly, nitroprusside is another option, but there is this risk of cyanide toxicity that is exacerbated with renal impairment as well. Breaking that down on this slide, I have the doses for your reference. They're all in micrograms. Another con with nasiratide is there is an increased cost associated with it. Nitroglycerin does have those improved outcomes, but there are still side effects we need to be aware of, including, of course, that hypotension, syncope, and paresthesias. And nitroprusside, again, the major thing to take home is the cyanide toxicity. So we need to be limiting infusion rates if patients have a reduced GFR if they are not making urine. And those are the treatment options that we have for acute decompensated heart failure. To give an overview of that, again, we need to be asking these questions. Are these patients congested at rest, and are they low perfused at rest? And break them down into these classification subsets. If we have a patient who is perfused, but they are fluid overloaded, the mainstay of treatment is going to be diuretics. If they are resistant to the diuretics, using increased doses, try a thiazide that acts at the different part in the tubule, or we can always add a vasodilator. If patients are fluid overloaded and they're low perfused, diuretics again are the mainstay and our first option, followed by vasodilators, followed by inotropes if patients have hypotension. And then if patients do have this low perfusion in class 3 there, and they also have hypotension, an inotrope would be a really great choice. Overall, our central themes of care to wrap up this presentation is if a patient's being admitted for acute decompensated heart failure, assessing the primary etiology is going to be essential. Are there any medications that we see that could potentially be exacerbating their heart failure that we could recommend discontinuing or changing to an alternative? 2 is going to be decongestion. If they present in fluid overload, we want to get that fluid off. And a lot of recent studies have supported being a little more aggressive in terms of those IV doses of our diuretics. And lastly, number 3 goes more hand in hand with chronic heart failure, but making sure we're optimizing the therapies for discharge to prevent that readmission. On this slide, I have my references for some of the pictures that I utilized. And that concludes my presentation. So thank you all for your time and attendance. I will now open if you have any questions. Again, feel free to type in the chat or speak out loud. Thank you again.